now moving on to Dr. Professor Katz, International Fellow of the American Academy of ENT, Professor Institute Exploration Fonctionnelle, the Gland Salivares, Paris, France. Professor Katz is going to talk to us about the role of basket retrieval and lithotripsy.
Mr. President, ladies and gentlemen, thank you and good morning. I just want to thank you also, Professor McGurk and Professor Ken, to invite me in your Congress. It's a great honor for me to speak about salivary lithiasis. My computer is not working, so we will do with the other. And you heard everything about lithotripsy and cystoscopy with Odd and Pasquale. My experience is a little bit different. I can check with the email. Because I'm not surgeon, I was one of the first to do the cystoscopy in 1988. That's quite a long time. But I'm not surgeon, I'm a radiologist, so I'm not doing surgery. That is another problem. And all the technique you will see here is non-surgical therapy. So let's see if it is working. So what about the salivary lithiasis and especially for the etiology? The etiology is, we think, and I think especially, that is a general disorder and a genetic disorder of the salivary gland. One of the pair, that means two submandibular gland or two parotid gland, and not a mix of parotid and submandibular gland. And we have families. And as you can see, we have quite a lot of families. If you make the talk with the families, you can find lithiasis in the family, such as from the father, mother, uncle, and everybody. The stone appearance, you can see that is always yellow, light yellow, dark yellow. The surface is smooth or rough, and the consistency is from soft to hard. And the hard is most frequency. So after, the composition is phospholipid, and you can see it's mixed or homogeneous, and the most of the salivary lithiasis are made by inorganic parts. That is the most frequency. And you can see this to the ultrasound or on the X-rays. The epidemiology is like for all of us who did salivary lithiasis performance, it's 1.15% of the population. The age is from 13 to 16, but if you see here, if you see here, the minimum age for submandibular lithiasis is 2 months. My first patient, very, very young, was 2 months old. And the parotids, the first one is, is 2 years old. And from the minor salivary gland is 56 years old average. The symptom is pain and swelling, the most frequency, 50%. Swelling alone, 46%. Pain alone, 3%. And diagnostic without symptom, 1%. Well, this is what we done before lithotripsy and before the cystoscopy. It was surgery, remove the gland, remove the stone, remove everything. especially for the salivary submandibular gland. We developed from 1988 non-surgical therapy. So in 1988, we have done the first endoscopy in the world with a very, very small endoscope made by Olympus. It was just a fiber, just a fiber. We have just the view. And you will see here, this is our first one. You see the endoscope here, the last one in 1988, and this is 1995, the last one made by Olympus. And the view was like that, very, very small. If you had seen the view before, like the view from Hodel, Pasquale, or by Johannes also, it's very big now. Before, it was like this, because it was not with the computer, it was just the view. And with the view, we had seen the dark like this, the stone, and we can make the first analysis of the inside of the salivary gland. We have not the, okay. So let's go, we have no video. This is the first basket probe. First basket probe was made also by Olympus. This is the basket probe like you have now, and we have all the same, but this one was the first one. It was 0.8 millimeters diameter, and this one 0.4 millimeters diameter, and we can go straight inside the gland and remove the stone. This is one of the first flexible endoscope with the laser inside. Well, this is the probe, basket probe here, push inside the gland. Here we remove the stone and the stone here. In 1996, 6 and 7, we had a new material made by Storz that's called semi-rigid, that's not flexible at all, and we have a working channel inside. That means that we can put basket probe here, just inside, with a working channel inside. That was more interesting for us. And you see the material you see here. Once again, that's what made by Aude. That was the first one with the working channel. Here you see basket probe also. You see a stone here. What is when we catch the stone? And in 2007, we have a new endoscope coming by a society called Polydiagnos that you have here. You have a desk here. And they made a flexible, that's really flexible, thinner, 0.6 millimeter with working channel, but disposable working channel. That's very interesting for us because you take the working channel, put the endoscope inside, and after the surgery or after the endoscopy, you throw it away. No sterilization. That's quite a good method, and I think that it is the best. Here you see the endoscope flexible. Well, how to succeed a basket retrieval? As Pascal told you, we have to do plain X-ray, ultrasound, and ciliography. We do ciliography because I'm a radiologist, and I continue to do ciliography. And you will see that in the best exam. Well, Plain X-ray is very, very simple. You do a panoramic or a flower on the mouth or anything like that, and you will see the stone. This is a child here. This is an adult, and here you have here, okay? After we have the ultrasound. Ultrasound, do not agree with Pasquale that he told you that lithiasis is visible at the size of 3 millimeters diameter. That's not true, because if you are a very good radiologist with a very good machine, it's 0.4 millimeters diameter. That's the new consensus that we have in radiology with the new machine. So 0.4 millimeters diameter, that's very, very small. And we used always the ultrasound, because with the ultrasound, we see the stone, we see the parenchyma, we know if the gland is functional. And it's very important for us, because if the gland is not functional, if with the sclerosis, we are not doing anything. So you see here, it's like all the ultrasound. You have here the stone, you can see the stone, you can see the duct, you can see the dilatation, you see the parenchyma, you see everything with the ultrasound. No radiation, nothing. After we do scalography. We do scalography because with the scalography, we put the injection inside the duct. We have a contrast. And with the contrast here, we see exactly where is the stone. You see here with the children, you see the stone here. You know that you cannot put your probe inside and remove the stone. Same here. You see the duct, you see the stone. You cannot take your basket probe, put your basket probe, and remove. If you don't do that, if you do just CT scan or cone beam or what you want, ultrasound or plain X-rays or something like that, you don't do this, you don't know where is the stone, you don't know how is the duct. And it's very important for us because we are not doing surgery. And we have to know exactly how hit the duct. So this is from the parotid, and here you have a small stone. You know that you can put the basket probe and remove. Same here, you have stone here, and we know exactly with the serography. After, I'm very sorry, we have no video. Okay, we have a video, and I will show you how we know that is the other video from the lithotripsy. Never mind. You have seen many things with the other speakers. Okay, it's not working. Forget everything. I will show you another time. Our results is very simple. You see, during such a long time, from 1988 to 2012, we have done 2,050 endoscopies. We have removed 1,463 lithiases with the basket probe. That means 1,084 on the submandibular gland and 415 on the parotid gland, included children. That is very important. And we never did a general anesthesia. Never. Never. So that results are, for us, very good and without any surgery. Well, the only incident we have, the accident, is we blocked a basket probe inside the parotid gland. That was in January 1992. And we have a parotidectomy and remove the stone and the basket probe. And after, we start with the lithotripsy. That incident pushed me to the lithotripsy. So cell endoscopy and basket retrieval must be simple, speed, and efficacy. if you don't do like this, do surgery. Well, about lithotripsy, lithotripsy is the same that Aude and Pasquale. We use for more than 20 years the same material. It's a mineral made by Storz, specially developed for the salivary gland, and we use this one. You see, this is the old one, and we have the same with Marc Marguerite also. That was the old one, and this is the new one. This is the new lithotripsy, new design, but the protocol is the same, technique is the same. We have the head of the lithotripsy here, put the head here, and get the shock waves on the patient. Well, lithotripsy can be used on all the lithiases found on the submandibular gland or parotid gland. The size is not important. It's from 1 millimeter, less than a millimeter, or 1 centimeter, 2 centimeter, 3 centimeter. The only thing is to visualize the stone with the ultrasound. So you must know how to do the ultrasound examination. And the contraindication is only the infection and a problem with blood discresis. Here also, we use the scalography before doing the lithotripsy, because if the duct is too thin, we have to know that the fragment will stay inside the gland. So this is the, it's working. This is a lithotripsy. Sorry, it was working. We can put again? You see here with the shock waves, you see the stone, breaking the stone here, and you have the small fragment moving here. You see a patient, our youngest patient, 6 years old. And it's not moving, no anesthesia, nothing. And we break the stone like this. And the stone, after, are moving inside the duct alone. Well, the results from July 95 to August 2012, we have treated 1,671 patients. The sex ratio is the same, about 51% for the women and 49% for the men. Well, the age is between 6 to 85. That means an average of 45.5 years old. The stone is from 1 millimeter to 34 millimeters. The repartition, you know, it's always the same. It's more for the submandibular gland than for the parotid gland. Here we have 1,081 for the submandibular gland and 590 for the parotid gland. The median section is 6, that means 1 to 12. The average of shock wave is always the same, is 4,000. And the fragment is evacuated spontaneously or with the basket probe or with the basket probe and the endoscopy. So we come back with the basket probe and the endoscopy. We remove and we break totally 1,106 lithiases. That means for the submandibular gland, 654, and for the parotid gland is 452. And we lived inside the stone 665 lithiases were partially destroyed. That means we live inside small fragment. And we leave the fragment here, and the gland is functional, and it's working. And we see the patient once a year, once every 2 years, and make another session. We have, like say Pasquale, 8% of a patient continued with the colic salivary, and 4% of the patient were they had a submaxillectomy, that's surgery, plain surgery, and 68 were treated by antalgic and antibiotics and corticoid. But we can say that all the lithiases were broken. That means 100% of the lithiases were broken with the lithotripsy. We know exactly how to break the stone, but we don't know exactly how to remove the fragments. This is the fragments just after the lithotripsy, and see the fragments 6 months after. See, and stone removal here. Same here. You see on the parotid gland, fragment coming here, here. This is our youngest patient, and stone here. Same here. You see breaking fragments. The undesirable after effect is very simple. It's dark hemorrhagia, petechia, and eye pain. That's very, very simple. This is petechia after a session. And during the 15 days after, we treat the patient because we had infection. So we give to all the patients after the session antibiotics, corticoid, and antispasmodic. That's our treatment. But we can say that we never had facial paralysis or lingual nerve paralysis after that treatment. In conclusion, during 20 years, we treat 4,085 patients were treated with non-surgical therapy. And we can say that cystoscopy and lithotripsy is a very, very good alternative before surgery, open surgery. And I repeat you, the success is only due to your right indication. If you put the right indication, you will succeed. If you don't put the right indication, you will follow. That means you have free exam to do. If you don't do the free exam before, you never succeed. And keep in your mind the scalography. Thank you very much. And I'm very sorry for the computer not working.
Thank you very much, Professor Katz. There's a job coming up in Dublin. Would you be interested? Would you be interested in coming in a job in Dublin? To work here in Dublin?
No.
No, all right. That's the usual.
But I can come with you.
Yeah. Thank you very much for that. Can I just ask you, and maybe I didn't understand it, when you do your lithotripsy and you've broken the stone down into multiple fragments, why aren't you at that stage doing a silidocoscopy and removing those fragments?
No, because we cannot put the cystoscope during the lithotripsy because you will choke the endoscope and break the endoscope. Okay, because the shock wave is quite power.
No, I mean after
it's bleeding. Right. We try, but it's bleeding inside, so we have to wash. And the patient also, he had a session with 4,000, 5,000 shock waves. If you put after the cystoscope and try to remove the stone, no, it's not good for the patient.
The other question I want to just ask is, you suggested it's not painful. And some of the patients who I've seen who've had this have said it's incredibly painful.
No.
No, not at all?
No.
Thank you.
No, the only thing is it's painful when they have a problem with the teeth.
Yeah.
If you have problem with the teeth, they feel on the teeth, they feel pain on the teeth, not on the stone, on the teeth.
Right, that's maybe what it is. Any other questions from the floor? Just go ahead, yes, thank you.
I'm sorry, I'm very old.
Thanks. Dear Philippe, it was a wonderful talk. I have a provocative question for you. How can you explain that with such a success, there is a very few radiologists involved in this technique? In every country in Europe, we have a very few men like you, radiologists, doing this technique. Do you have any explanation for that?
Why in the technique is so successful that you're doing, do we not have more radiologists like you doing what you're doing?
We have some radiologists doing, but not a lot, because the problem is it's a too narrow subject. It's a too narrow subject. So radiologists today, they don't want to do a too narrow subject. They are doing MR. You are doing, I know that you are. They are doing MR scanner for the heart, for the breath, for everything. The stone and particularly lithiasis, it's too narrow, so they don't want to do. I had one in my office, especially a young one, a young female, since a week, and she after 4 years, she gone because she don't want to be too narrow.
Professor Zink.
Just want to give also a comment and support for him. In Germany, we have, I think, about five departments doing that regularly. Also in Switzerland, 2 or 3. And the problem of the method is that it never came to the United States because there is no FDA approval. So if a technique is not performed in the States, it doesn't come back to Europe.
Yeah.
That is it's very interesting. We have seen that with the endoscopy. That's amazing. We started endoscopy in the 80s and 90s. Then Nalieli and Marshall started it again in end of the 90s with the new endoscopes. We started in 2000, and then everything went to America, and now it comes back. It seems that sometimes it's the only new thing we have in ENT.
Thank you. We'll have Maura first because she's a lady, Peter.
Thank you so much, Leo. Just a thought. You said they complain of the teeth are a bit sore. What about somebody who's got a lot of fillings or crowns with cements and things on their teeth? Do they get any damage?
Yeah.
Do the people who have crowns or fillings, do they get damaged by the extracorporeal?
No, never.
Peter?
In fact,
No, keep going.
it's the crown or the implant or something like that. They never touch with the shockwave, and they never moved the teeth also. But it's only the resonance of the shockwaves going straight to the teeth, and especially with when you have hole in the teeth.
Thank you very much. I think I was always taught that you should never be the first person to adopt a new technique nor the last to abandon an old one. And the evidence that we've heard today is that we should be doing this and we should not be sticking to the old techniques. My question is, how big a population do you need for a center doing this work? I send my patients to Mark because I have a small population. But if you want to set up a unit and you were planning a health service, how many centers would you need in the UK?
How many population? Well, I'm in Paris, so I start in Paris. In fact, if I were in a small city in Normandy or south of France, I never had enough people. So when I started, very long time ago, we have 10 million population of Paris and the suburb, 12 millions, that's quite a lot. So we have 1% of the people had stone inside the gland. So we have enough people coming to make that kind of therapy. But you must have quite a lot. If you are alone in the country, you have nobody. You will see once in your life, but not as we can have. And the other thing is to make publication, congress, communication, courses, do everything to make the promotion of that technique. So I start very, very early to go, and every university in Paris, we have 12 universities. I have done courses in the 12 universities at the beginning to say, okay, I have new techniques, so you can bring me your patient. If you don't want they have surgery, bring me your patient. That I start like this. But if I were in, for example, in a small city in middle of France, I had few people.
Thank you very much to Dr. Katz for a wonderful talk.
You.
And also thank you very much to all the other speakers from earlier on. Thank you. Can I ask you all to get back as close as you can to 11:30? If we don't keep to time, it actually causes problems later on. Thank you.